So some would say, well, yeah, that's true. Well, maybe bankruptcies are not as common. The copays are there, but we have to establish some value, and I think that's a fair proposition that we cannot divorce what is being paid for medications from what the value is for and what is it that we're getting for the dollars spent in this medicines. So one of the most common ways to do this is through QALY, and I'm going to talk about some of the value networks later. But let's start with talking about the quality. So the quality stands for quality adjusted life year, and what it really does, it estimates a dollar value for the extra year of life post diagnosis. And the problem is with the QALY. The QALY actually make an adjustment, a negative adjustment, since one leaving in a post-diagnosis with a toxicity or some residual problems from the cancer itself will have a residual quality of life that is lower, and therefore then we have to actually make that particular period of life less valuable. Now, you could say this is a drug or you could say this is a patient's, but the reality is that these metrics are used to essentially deny the care and the treatment for patients. And I think this is ethically dubious. Several bioethicists have pointed this out. There's two articles that I would direct you to. One is by Dr. Harris. The other one is by Dr. Pettit. I myself have written about this, as well as my collaborator, Jennifer Hinkle. Because when you come think about it, cancer patients are now telling us that their life is less valuable. If anything, it's more valuable post-diagnosis. Because you're facing the possibility of death. You're facing the finite nature of the human life. So I always say, you might know what you're doing 6 months from now, but it's not unusual for a cancer person or a cancer patient to know exactly what's happening next week and the week after, and whether there is a graduation or a family event that they want to get to. And some of them would tell me that if anything, post-diagnosis, toxicities and all, the value of every day is greater than it was before. So my argument would be there that if we are to use a metric that looks at incremental costs for years, let's just simply use life years. Or you could use, like was presented before, the quality adjusted cost of care, but not the quality. Another important aspect with the QALY is that most of our government organizations are not allowed to use QALY as a way to determine whether a treatment is worthwhile or not. And that creates a problem. I fully admit that, because we don't have universally accepted metrics of what could be used to determine the value of that extra life. However, there's an important caveat to this. The absence of that metric does not, by in and of itself, justify that we use QALY as a way to determine the value of life post-diagnosis. So it is used. I'm not pretending it won't be used anymore, but I will argue that the QALY probably should go, because that is just something that it's different from what cancer patients would tell us. And others have pointed out some of the obvious limitations. I think some of this comes in the Harris article. If you really want to focus on QALY, that would mean that you would have to invest all of your healthcare resources in neonatal units, prenatal care, etc., and almost none of your resources in advancing age individuals. And as we all know, that's a big part of what we spend in healthcare. And again, a larger discussion, but that's just the framework upon which QALY resides.